Bronchiolitis season. You know what it means. For every single one of us in pediatrics, it's a wave of sick infants and some really tough clinical decisions. But here's the thing. The way we manage it is changing. The latest guidelines are really steering us towards a less is more approach. And in this explainer, we're going to break down exactly what that means for our day-to-day practice and, of course, for our patients. So we're going to follow the patient's journey right from the moment they come through the door. We'll start by locking in the diagnosis, then we'll dive into the biggest shift in practice, which investigations we really need to avoid. From there, we'll climb the treatment ladder, tackle that critical decision of who gets admitted, and finally, we'll talk about how to ensure a safe and confident discharge. All right, let's jump right into Section 1, Recognizing Bronchiolitis. First things first, we've got to lock in the diagnosis and think about what else it could be. Okay, the most important thing to take away here is that bronchiolitis is a clinical diagnosis. It's all about what you see and hear at the bedside, not what some lab test tells you. You know the story. A child under 2, they had a bit of a cold, and now they're here with a cough, working hard to breathe, and that classic expiratory wheeze. But, a wheezing infant doesn't always equal bronchiolitis. We've got to consider the mimics. Could this be the first time we're seeing viral-induced wheeze, or maybe even early asthma? Is there a sneaky pneumonia hiding in there? And hey, in an unimmunized baby, you can't forget about pertussis. Then there are the rarer things like a foreign body, aspiration, or even cystic fibrosis. Our clinical exam is absolutely key to sorting all this. So, Section 2, Investigations. This right here is where we're seeing the most significant change in practice. The new guidelines are crystal clear. We need to stop all the routine testing and only investigate when it's going to directly change our management plan. And this is the question we really need to start asking ourselves with every single patient. In a typical case of bronchiolitis, what tests have we been ordering just out of habit that we should now be actively avoiding? This is the new default setting. For the vast, vast majority of kids with bronchiolitis, the right number of investigations is 0. Let's look at the specific tests we should be staying away from. So what does that mean in practice? Well, it means no more routine chest x-rays, which just exposes them to radiation without changing what we do. No routine blood cultures unless we're seriously concerned about sepsis. No automatic U&Es unless there's severe distress and we think they'll need IV fluids. And viral PCR, we save that for very specific cases, like an immunocompromised child, where knowing the virus would actually change our treatment. So when do we test? This table lays out the very specific indications. We think about a blood gas if we're worried about respiratory failure, a respiratory rate that's stuck over 80 or a rising PCO2. We might get a chest x-ray if we hear a murmur or the presentation is just weird, it's not typical. Blood cultures are for a high fever or clear signs of sepsis. And U&Es? For the really sick kid on IV fluids. These are targeted exceptions, they are not the rule. Okay, on to Section 3, the treatment ladder. We've made our diagnosis, we've decided against routine tests. So now, let's talk about respiratory support. The guidelines frame this as a really clear, step-by-step ladder. At the very bottom of the ladder is just good old supportive care. Honestly, for most kids, just making sure they're hydrated and nourished is all they need. If they need a little more help, we step up to standard oxygen. The next rung up is humidified high flow, which can give them a little bit of positive pressure and really help with the work of breathing. And right at the top for impending respiratory failure is CPAP. Now, here's a number to burn into your memory, less than 92%. For our most vulnerable little ones, I'm talking infants under 6 weeks or those with other health problems, we have a much lower tolerance for hypoxia. They just don't have the reserve, so we don't wait for their SATs to drop to 90. We jump in earlier, at less than 92%. This slide really reinforces that core theme we've been talking about. For most children with bronchiolitis, there is just no good evidence to support using bronchodilators, antibiotics, or chest physio. The evidence isn't there. So our management really boils down to 3 simple things: oxygen, hydration, and time. Moving on to Section 4, admission. Man, this is often the toughest call, isn't it? Who can we safely send home, and who absolutely needs to stay with us for support? The guidelines are really helpful here, breaking this down into absolute and relative criteria. The absolutes, they're non-negotiable. Any apnea, SATs dipping below 92% in an at-risk infant, or feeding that's less than half of normal, those are automatic admissions. The relative criteria are more about our clinical judgment and trying to anticipate risk. A really young baby, maybe some social concerns, or a child who's showing up on day 1 or 2 of their illness,
These are all things that should make us pause and consider admission, even if they don't quite meet those absolute criteria yet.
And that brings us to our last section, discharge and education. Look, getting them through the acute illness is only half the battle. A safe discharge is about way more than just clinical stability. It's about making sure parents are confident and educated. So here is our discharge checklist. The child needs to be clinically stable, they have to be taking all their feeds by mouth, and maintaining an oxygen saturation over 90% in room air. But that fourth point is just as crucial. The family has to be confidently educated on all the red flags and know exactly when they need to come back. This is the safety netting information that has to be crystal clear to every single parent. We need to tell them, come back immediately for any cyanosis, if they start working harder to breathe, or if their feeding drops off significantly. We also need to teach them to watch for signs of dehydration, like not enough wet diapers, and to look for exhaustion or lethargy. And finally, we have to give that critical advice. Absolutely no exposure to passive smoke. And this is really the heart of the matter. As we start to do less, fewer tests, fewer medications, fewer admissions, our job increasingly becomes about communication. Building that trust with families and providing clear, concrete safety netting advice is the absolute key to making this whole less is more approach successful for everyone, especially for the families we serve.